Okay. Uh, Good morning, everyone. Today is July 16th, and this is the Incarceration Prevention and Reduction Task Force Behavioral Health Committee. Bill, do you want to just scroll down a little bit on the agenda for me? Okay. I'm going to do a land acknowledgement statement, and then we'll go into introductions. We have quite a few new people here today, so I want to make sure that we all get to know each other a little bit. So before we begin, we acknowledge that we're gathered here on the traditional and unceded territory of the Lami, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us here together today. And please join us in uncovering such truths at any and all public event. And with that, let's do Joe, let's take the agenda down for a minute, and then let's do so we can all see each other, and then let's do introductions. I'm gonna go in the order that I see folks here on the screen, and if you can just briefly, tell us who you are and maybe just a sentence or two as to your background and why you are why you joined the committee. So Bertie, I'll start with you. You're muted.
Okay, I'm Bertie Safford. I'm a retired family physician in Ferndale, Washington, and I am a member of the IPRTF. I'm not an official member of the Behavioral Health Subcommittee, but I very much enjoy listening and participating. Thanks.
Thanks, Bertie. Peter?
Hi, I'm Peter Frazier. I am co-chair of the IPRTF and been working on these issues for about 5 years. I was the guy who started the Heliotrope Hotel and Hotel Leo, which brought me into close proximity with folks that we are trying to support and systems that are to support them. So that's how I got to it, and I'm very interested in helping all of you and us move things forward. Thank you.
Thanks, Peter. Arlene Feld?
Yes, I am at this stage, if you can believe it or not, supervising interns and who are going to be counselors. I've spent my whole career counseling and variations of counseling. I was co-chair last year of the Law and Justice Committee, and this year I am just a member like you all. And I've done individual therapy, family therapy, and child therapy over the years. I've written a book. I've taught, and I've been I worked for crisis respite for 9 years before this. So I'm retired.
Thanks, Arlene. Appreciate it. Steve Larson.
Good morning. My name's Steve Larson. I'm with the Bellingham Fire Department as one of the community paramedics. And as part of being a community paramedic, I thought it'd be great to be part of this team, and it would dovetail well into my day-to-day work activity and seeing how I could best contribute to this group.
Thanks, Steve. Stephen Gockley.
My name is Stephen Gockley. I'm a former co-chair of the Incarceration Prevention Reduction Task Force, a member of the Legal and Justice Committee as well as this committee, and was part of the planning team for the Justice Project.
Thanks, Stephen. Jill, do you want to just kind of tell us or tell the committee what you do?
Yes, good morning, everyone. My name is Jill Nixon. I'm a legislative coordinator for the Whatcom County Council and staff facilitator for the full task force and its committees. Thank you.
Thanks, Jill. Brian Estes.
I'm Brian Estes. I have a long career in program evaluation with the Federal Government Accountability Office and with King County. I'm I'm the treasurer of the National Alliance on Mental Illness, the Whatcom County chapter, and I'm also on NAMI Washington, the state organization's public policy committee.
Thanks, Brian. Cedric Johnson.
Hi, everybody. My name is Cedric Johnson. This is my first meeting. I'm a lifelong Bellingham resident. I sort of grew up working at Unity Care Northwest, formerly Interfaith Community Health Center. And for the last 2 years, I've been writing grants and doing consulting with federally qualified health centers all over the country. So I have a lot of interest in our local community, and the impact of behavioral health and sometimes the lack of services. And then through my work, I'm constantly learning about what people are doing in other communities, trying to get funds for people to serve communities all over the country. So I'm very interested in which of those models could be applicable here.
Thanks, Cedric. Keith Johnson.
Keith Johnson, a patrol lieutenant at Bellingham PD, formerly outreach lieutenant, and had an opportunity to work with a lot of our community partners. And so that's kind of carried into my present role.
Thanks, Keith. Dr. Wu.
Hi, I'm Ying Wu. I'm a retired family physician. In that capacity, I did medication for opiate use disorder in the past. So that was one of the things that got me connected to this. I was on the board of Chuckanut Health Foundation for 9 years, and now I'm a volunteer intern at the Health Foundation. And I didn't really originally think this was relevant, but actually I've been with the Mount Baker Ski Patrol as a volunteer for 20 some years. And as I think about volunteerism and the workforce requirements, that actually has turned out to be more relevant than I had realized initially. Very glad to be invited to be part of this.
Thanks, Dr. Wu. Jake.
Okay, yeah, thank you. Jake Webush, the administrator for district court and probation, formerly the probation manager. Been involved in this committee for some time, as well as the pretrial and legal and criminal justice one. So glad to be here. Thank you.
Thanks, Jake. Steve Harris.
Hello, I'm Steve Harris. I'm the undersheriff with the sheriff's office. Been in law enforcement for nearly 30 years now. And as everybody is aware, there's a lot of intersection with law enforcement and the mental health and behavioral health community. So we just want to be part of the solution moving forward. Thanks.
Thank you. Melora.
Hi, good morning, everyone. Melora Christensen. I'm the Response Systems Manager with Whatcom County Health and Community Services. I'm a clinical social worker, and I've been working with the vulnerable adult population for the past 12 years, and just really excited to be a part of this group and support all the great work. The Response Systems Division runs and operates in partnership with fire and EMS and law enforcement and corrections. Grace lead the alternative response team, corresponder program, mental health court, and recently started a street medicine team with our nurse practitioner and an RN. So very much behavioral health, all things behavioral health, and excited to be able to contribute here.
Thanks, Melora. Heather?
Good morning. My name is Heather Flaherty. I am here appointed as a citizen representative, but I also am the executive director of the Chuckanut Health Foundation, and have been following the incarceration task force since it started. So really glad to be here.
Thanks, Heather. Perry. I think you might be muted.
Sorry about that. Good morning, Perry Mallory, Response Systems Division Supervisor. I get the opportunity to work with Melora, involved in many of the behavioral health components and aspects, background in mental health and substance use disorder professional for many years. I also am the current chair for the crisis stabilization facility, and support those folks and the utilizers of the facility on a number of different levels. Great to be here.
Thanks, Perry. And let's see, I don't see, did I miss anybody? I think I got everybody. Okay. Well, I'll just take a go then. I know most of you, but my name's Dan Hamill. I'm the president of Bellingham City Council. I'm the co-chair of this behavioral health subcommittee for the task force. And I'm not going to do my whole curriculum vitae, but I've got a little bit of background. I've been doing this for a bit. Let's go to our first order of business, and that is the election of the co-chair. Just to give a little bit of history, Mike Parker, formerly of the Opportunity Council, was my co-chair for several years on this committee, and he went into private practice, a counseling practice, and so he's not able to be the co-chair any longer. And I've asked Stephen Gockley to be the co-chair, and Stephen agreed to that, but we have to vote him in. So voting members of the committee, even new folks, if I asked you to be on this committee, you can vote on this. Jill, and any other parameters on the vote?
No, thank you.
Okay. So I'm going to make a motion. I need a second to for Stephen Gockley to be the co-chair of the Behavioral Health Committee of the Incarceration Prevention and Reduction Task Force.
Dan, I will second that.
Okay, so I have a motion by the co-chair and a second by Brian Estes. Any further discussion pursuant to this item? Okay, seeing none, all those in favor signify by saying aye or raising your hand, or both. Aye.
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 Okay. Jill, did you get a count on that?
I would ask for a no vote and an abstain.
Okay.
Is
Okay.
anyone opposed to the motion?
Is there a no vote? Anyone voting no? Okay, looks like it passed unanimously.
Thank you, everyone.
Yeah, well, thanks for joining us, Stephen. Hey, Stephen, I noticed your volume's just a little bit low. I don't know if you can adjust that or on your computer.
I'll try.
Okay, yeah, that's fine. So several of the folks that are new to the committee are going to make presentations today. They're, shortish presentations, but it's an opportunity for us to dive a little bit deeper into the work that they are doing. And so I just want to take these opportunities to understand each other a little bit better. And then one other thing that Brian Estes and I have talked about, and others, is that we want to make this committee an action-oriented committee. So today is going to be some presentations, but in the future, what I'd like us to do is focus in on things that we can take action on. But for today, let's get to know each other a little bit better. And Jill, can you put the agenda back up on the screens? Okay. Can you just scroll up just a touch? I think I got it, but I just want to make sure. Okay, that number 2 is the appointment of co-chair. Brian, I see your hands up.
I just had a question. Is Courtney Taylor still a member of the committee?
She is not.
Oh, okay.
Yeah.
Do we have anybody from that office still?
Nate, I believe. I don't think he's here today though.
Okay.
So, and just for quick background for everyone that's on the call today, I am trying to fill this committee with, round it out a little bit more with providers, people who are working within or working directly with folks that we're trying to serve here. So just so you have that background. I'll take number 3. And Melora, please feel free to chime in. And Jill, you can go ahead and put the or take the agenda down and put us back up. Okay, good. Melora, I'm gonna need some help with this one. I can give everyone the background of kind of what this is about. This is Dijwali Clinic, Swinomish tribe. About a year and a half ago, about a year-ish ago, the city of Bellingham council passed a public use ban, and this was in response to open air fentanyl use in particular in downtown, but all over the city. As you well know, prior to that, the state legislature had rescinded the felony charge for simple possession. So it was essentially legal to have drugs on your person. So the council, at the request of the mayor at the time, passed this law that said you can't use in public. And so it made the papers, and we got a call from Swinomish saying, you know, hey, we have a clinic that is off of Highway 20. It's they treat opiate use disorder and provide medical and dental and counseling, NA, AA, a lot of different services. And so a group of us went down, including our current police chief, myself, and another council member. Perry, you were there. Dr. Thompson from the health department, and I might be forgetting a person or two. We went down and had just a wonderful conversation with their providers, their executive director, Bev Keys, and one of their tribal elders, Leon John, and many others, and just had a great conversation. That led to the development of a relationship that I embarked with Bev Keys and Leon John. And at one point, several months later, I was contacted by Bev Keys, and she said, you know, look, we want to provide Bellingham with some mobile medical units for opiate use disorder treatment that would include Suboxone and methadone. And of course, I'm a council member. I'm not an operations person, so I was very grateful. I still am, like, to the point where it's like it's just very, very heartfelt that the tribe would provide that, you know, that opportunity for Bellingham and folks from Whatcom County. So several conversations later with Whatcom County Health Department, and the tribe came up and looked at a space, and we continue this relationship to this day. Several council members and myself just went back down to the clinic and did a tour and really just kind of strengthened that relationship. As to the logistics, Melora, I think I'm going to ask you to maybe, if you'd be so kind as to maybe provide some what that could look like in the going on or moving on into the future.
Yeah, thanks, Dan. Yeah, I'll just echo the gratitude to Swinomish Tribe and the Dijwalik Wellness Center. You know, what they are offering to this community is something that would be so incredibly challenging for any of our local providers to take on. They are going to have 2 mobile medical units that look like large RVs that will actually be able to do the dosing. And so they do medication assisted therapies and really work with the whole person. If, as Dan said, their wellness center in Anacortes is really, I think, the closest thing to true wraparound trauma-informed care that we have in this region. It's really beautiful when they're able to address every aspect of someone's life while they're trying to engage in recovery. So it's trauma-informed care in action. If anyone's ever asked what TIC in capitals means, I'll tell you it's happening at Dijwalik. And so them being able to bring that service to Whatcom County as a gift to this community is just incredible. So we are looking at our division behavioral health campus, which the Ann Deacon Center for Hope is already there. Our alternative response and co-responder team is already housed at that location. And we have a clinic space there that is not being utilized right now and is already owned by the county. So the hope is that those MMUs, mobile medical units, and that clinic space will be able to be utilized for this. And the plan is that they would be operating 6 days a week in the morning, pretty much 8 to noon. And hope to provide some additional services like counseling and other supports in that space. And this isn't quite official to like Dijwalik has asked that we not do press releases yet until we get everything really kind of dialed in and everything signed between the county and the city and Dijwalik and Swinomish. But it's looking really good. And as Dan I mentioned, they're happy for this to be shared with the community as something that's coming. And I would say this could be operational in less than 6 months. So that is the hope. And once we have more information on the operations and how people will be able to access services there, we will definitely try to help get the word out.
Thanks, Maura. Any questions on this item? Dr. Wu?
Laura, do you know how many, it sounds like this is going to be continuing care rather than sort of just getting started. Do you know how many patients they're able to follow with those hours?
Yeah, so they are open to starting patients and then being able to provide ongoing care. And they are saying that they could serve up to 300 plus people daily. So could be a very large impact if it was really utilized at that level. Down in Skagit, they do have a really robust transportation system. They have many vans that are on a loop, and they're able to give rides. It's unclear if they'll be able to provide that type of transportation in Whatcom. And so I think we'll be wanting to really figure out how do we get folks there since often for methadone it's a daily dosing. So it can be, quite challenging for folks to have that daily need. So yeah, but they're anticipating being able to serve at least 300 people or more a day.
Stephen?
First, thanks, Dan, for initial coordinating, and thanks, Melora, for spearheading the coordination. This is just a fantastic step forward for the community. My questions, and I know you're still in discussions, but my questions come out of our experience with the Ann Deacon Center and the providers there, where we are the landlords and not a contractor for services. We've had difficulty accessing their data. And I'm just wondering what you're envisioning the working relationship with the clinic would be in this regard.
Yeah, thanks, Stephen. That's a very good question. A similar setup in that we will not be paying for any of the operations. Deejwal Leak is covering all of that operational costs themselves. What we are gifting in this scenario is the use of the space. And of course, we want to have our staff that are in serving similar populations to be coordinating as much as possible. What I think is going to be very, very important is that who is able to be served. We need to get that out to the community, because what everyone's going to hear is there's a new resource. We should just drive them to Division and drop them off. And that's going to help with all these other things. It is a huge piece of the puzzle, but Deejwal League is going to have a process for new patient intake, what it takes to continuing to be a patient. And so we're going to need to make sure that all of our providers have that information. And that's something that Perry and I will be working on. It's not medication assisted therapies isn't going to work for everyone. Right. And so this is going to be a new opportunity for folks that are interested. And we already have good MAT and MOUD providers in town. So we're also going to be working to make sure that Deejwal Leak is connected to the existing providers like CMAR and Cascade Medical and Ideal Options and others. So there's just a lot of coordination that's going to have to happen, and really our community understanding who can be served there and what it's going to take to be served there.
If I could follow up for just a moment, I think for our purposes, this committee and the Justice Project, one of the stumbling blocks has been access to data at the Ann Deacon Center. And that's especially important over the next years as the Justice Project plays out and we try to integrate a system across previously siloed systems. So I don't know if you've broached this with the clinic, but I'd certainly encourage us to have access to anonymized data so that we can see recidivism in the criminal justice system and all sorts of cross outcomes.
Yeah. It's such a great point, Stephen. So the MOUs are, that's where we're at right now. The lawyers are talking to each other. And that's really where we would want to put in, you know, this is what we're hoping to get from DJWA. And that would be our request. And then they can counter with that. So I appreciate the reminder. And I think it's the right, we're in that process right now where we're trying to determine what the relationship is and what the expectations are. We're in a, it is a unique situation where this is a service coming to us that, again, we don't have a ton of oversight over, because they're doing all of the heavy lifting of getting the certification and paying for the operations. But that is in our ask, and I think I don't see any reason why DJWA wouldn't be interested in giving us the de-identified. The question is, where does that data live and who manages it and who analyzes it? So yes to all the things, and we will continue to go down that road asking for that.
Peter?
Yeah, Melora, thanks so much for this. I know that you are not going to have the precise answer to this, but what portion of the population that is in need of these services do you think 300, if it was maxed out, it would cover? And then also, I was in a presentation by Erica Lautenbach yesterday indicating that we're soon, hopefully, going to have people who will be available to follow up within 24, 36 hours with people who have had overdoses. And I'm wondering if there is any, if there will be coordination between those folks and this program.
Yes, in fact, they'll be housed in the same office. Peter, can you clarify your first question? I just want to make sure I understand the population question.
Well, this kind of goes back to what Stephen was saying. In a time when we just simply don't have great data around things, one still wonders what portion of the need, 300, 300 people a day covers. How large a bite out of our problem, or the needs, would this program take care of?
Well, I would say that this could make a significant impact to the county-wide concern. Again, with methadone and medication-assisted therapies, if you are having a daily appointment, you have to be in a pretty stable place in order to do that. And so what's great about Swinomish and DJWA is they offer all of the different medication-assisted therapies. So, right, methadone might not be the right opportunity for someone that is unsheltered or is really struggling with behavioral health. There are other medications that they might start with. I can see that folks that maybe are not as acute and maybe not seen, maybe aren't booked in the jail or aren't reaching the threshold for grace or community paramedics to reach out to, that this would be folks who this could be more prevention and getting people stabilized. And that's so needed, right? We have so few options for that. But this is also going to be, how can we stand up the additional operational supports like transportation to make sure that people can access this. So that's where I really see that's our role as a community. Okay, they're bringing this service. It's going to be there 6 days a week. What do we need to do to really make sure that the impact is as large as it can be? But Peter, I think it's a significant impact if they could really serve 300 people a day, if that many people were accessing it. And then I'm sorry, I totally spaced your second question. I should have written it down.
No, you covered it.
Okay.
How stable is this funding? Do we know? Is there any reason to believe this is not going to go on for some period of time?
and Dan or Perry, but I don't have any reason to believe that this would shift unless we had a radical shift in federal administration. So.
A couple of things. I just want to answer that or try to answer that question. I don't see anything that would derail this process in terms of the funding component. The way that the tribe is funded or the clinic is funded is different than how local funds occur. And then the other, Peter, to your other question, in terms of the treatment numbers, there's another clinic in town called Bellingham Comprehensive Treatment Center. It's located on Northwest Avenue. And I did a tour with Dr. Thompson from the health department recently, and they claim to be treating about 320 people or up to 320 people a day. So this perhaps doubles that or close to doubles that amount of treatment. But Melora is dead on correct when it comes to people needing to be in stable situations for methadone in particular. The other MAT can perhaps provide some level of treatment, but it remains to be seen on that one. And I know that Stephen, I see your hand up. Go ahead.
I was just going to ask Melora, you call them mobile clinics, and yet all your description is centralized to the location on Division Street. Can you clarify those two facets of this?
Yeah, so these controlled substances are very well monitored. And so Swinomish has to go through a certification process with the DEA and basically has to ensure that those substances are secure. So every day, these mobile medical units will start in Anacortes. They will drive to Bellingham. They will do services for 4 to 5 hours, and then they will drive back to Anacortes. And so there will be security on those vehicles, and there will also be some security at the division site. So they need a location where they can have the right power for those units. And then they also need the additional office space to be able to do their counseling appointments. So we're providing that, and they're providing these units that are certified to provide this service, but every day they'll have to go back to the mothership. So that's how that is set up at this point.
I had envisioned them using 1 day a week out to Kendall, and that's not the way it's going.
No, unfortunately, they need 50 amp power wherever they're going to be, and then they need office space at the same time. So at this point, it's mobile because the units are going to be moving daily from Anacortes up and back. But no, it will be at that one location. And I just did want to ask Peter had mentioned that Erica shared that we're moving forward with some positions that could do some kind of resource coordination, recovery coordination after an overdose. And so we are actively working to try to get those positions in place, and they would be located at the division property and be able to coordinate with our existing transportation staff. So we have one staff right now who's able to provide transportation throughout the community. So if we're able to bring on these resource coordinators, they would be doing follow-up with someone, hopefully 48, 72 hours after an overdose, and trying to figure out what that person would need to connect to services, and then maybe providing transportation. So they'll be working very closely with not only D2L, but the Ann Deacon Center for Hope, and then the response systems and our other partners that are working closely with us.
Okay. Any further questions on this item? Okay, seeing none. Jill, if I recall correctly, the next item is from Lieutenant Johnson from Bellingham PD to speak. Is that correct?
Yes, that's correct.
Okay. Lieutenant Johnson, the floor is yours.
All right, thanks, Dan. Yeah, I was just asked to provide kind of an update from the police perspective on drug issues, particularly maybe downtown, and kind of what we're doing to address those, what our plans are moving forward. So I guess just kind of in general, fentanyl is obviously the top concern. The trend we're seeing is, a year ago, people were using mostly pills. Blues were the nickname for them. We've seen mostly powder recently, so it's kind of transitioned to that. Meth is also prevalent. We haven't seen much heroin. Fentanyl has pretty much taken over that for the most part. I think in general, methamphetamine use provides or creates more problems for us as far as like violent individuals. But the fentanyl use comes with its own challenges, overdoses, and things like that. So just kind of a real general statistic of overdoses that we've documented here at the police department. And there are different ways to query these stats, responses versus reports, but these were ones that we documented, and it just kind of gives a general trend of what's been happening. In 22, we had 9 of those reports. 23, we had 106, and this year we have 103 to date. So probably we'll be up over 200 by the end of the year. So definitely a sharp increase, and that's coincided with the prevalence of fentanyl use. For us, as far as drug enforcement, there's been some challenges. As Dan referenced earlier, went from possession of hard drugs, went from being a felony to, for a while, it was nothing, and now it's back under state law to being a misdemeanor. It's a little tough for us because we used to be able to potentially steer people towards services with the specter of a felony charge hanging over their head. Hey, we'd like you to go this route instead. We don't really have that anymore. And so when we're offering people options, they kind of know that the criminal side of it is not going to be impactful. It's not going to be a deterrent. And so that's something we've had to work around. What we are doing right now for drug investigations, or when we contact someone that's using drugs in the city, is we'll do a citation by referral, which goes over to the municipal court prosecutor's office. We can seize any drugs that they have with them, but we found that that's not a big deterrent. The prosecutor's office is waiting for some back end things to come into place that are mandated by law before charging people. And so, basically our contact with people in the field is, hey, we're going to have to take your drugs. You will be hearing from the prosecutor's office. And then, that's kind of in limbo. And so it's not a big deterrent. Some people would argue, well, you're able to take their drugs, but particularly with fentanyl, we're usually talking like $5 or $10 worth rather than taking somebody's stash away in a way that's going to impact their use. So for current police actions, what we've been doing, the mayor put out kind of the all hands on deck at the beginning of the year. And since then, we've been doing patrol shift emphases. We have 8 patrol shifts that work throughout the day, and they kind of overlap. One group works one week and then they're off for several days and another group comes in. So in total, we have 8 shifts. We've asked each of those shifts to spend an hour per week doing a full shift downtown emphasis. And the city has combined that with increased cleanup efforts from Public Works. And I think it's been pretty effective in the downtown core. In the central business district, the alleys, I think, are a lot cleaner. Some of the businesses downtown had really been under siege for a while. And so that's been a success. What we have seen is that behavior hasn't stopped. We've just kind of pushed it to the outskirts of downtown. And so now we're getting complaints and dealing with issues with the surrounding businesses and not necessarily right in downtown. The other thing that we've been doing for the past several months is overtime foot patrols. With our directive to the officers has been we want increased engagement with the public. We want you talking to business owners, and then also doing enforcement with any kind of crimes against public order or things like that, drug use in particular. Longer term, we have a couple of irons in the fire. The one that we're doing immediately is we are putting a couple more people into the regional drug task force. And that was something that we had participated in before. We, due to staffing issues, we pulled out of that, and we had the department had shrunk down to basically our patrol operations and our investigations or detectives division. Our staffing is getting back up to a point where we can start looking at some of those specialty positions again. That would include the task force, things like the behavioral health officers, bicycle patrols, things like that. There's no set time frame for that, but those are things that we're working towards as a department, and they've been effective in the past for quality of life issues. And we felt very supported by our new chief and the mayor to do those things, and the officers like it too, because it's something different than working patrol. Yeah, the drug problem specifically is obviously a complex issue, and I'm just speaking kind of on the police enforcement side of it, because that's kind of our role, which is enforcement, deterring, hopefully, and one of our goals that we've been working towards is referring people towards other treatment options and resources in the community, and worked with Melora and lots of the different groups that we have to make that happen. And it's always a challenge for us. We're trying to balance the needs of affected individuals versus kind of the community at large, and some of the problems that are created by drug use and other corresponding behaviors. So yeah, lots of programs going. I think there's general agreement that we just need more of that, more resources, but it's a process and takes time. So yeah, that's kind of where we're at. We're always encouraging our officers to utilize the resources that we have, and I think that's going well. Cops can be kind of notoriously stubborn about deviating from what they've done in the past, but I think we're making good progress with that, and we're getting good feedback. So that's kind of where we're at. Happy to answer any questions that people have.
Thanks, Keith. Any questions from the committee? Peter, then Brian.
Hey, Keith. I recently read a police report of a tragic overdose of a 16-year-old girl at a party up in Ridgemont neighborhood. And it just got me to thinking about how often, if at all, we are investigating where the upstream flow of where those drugs are coming from. Do we have resources for that sort of investigation at all to find out, maybe start with where she got those drugs, where that person got those drugs, and up the chain? Or is that just beyond us right now?
Yeah, there's 3 different groups that would do that. When we have an overdose, particularly something that results in a death, our investigations division will do that. We have been charging more people with controlled substance homicide, which is something that had not really happened for a long time because they hadn't had any success with those prosecutions. But that's something that the prosecutor's office has been doing more lately, and it's been having some success with. So that's good. Our investigations division would do that. The task force their kind of mission is looking at mid to upper level dealers, which are the people that are bringing drugs into the city. We did have for a long time a special investigations unit at the police department, which concentrated a lot more on street level and maybe up to mid-level dealers. We don't have that. That's one of those units that, when staffing permits, we would like to re-implement. So yeah, there are different entities that look into that. And our goal in putting a couple people back at the task force is to have kind of a Bellingham-centric mission for exactly stuff like that.
Brian?
Yes, I just had a question about, does the task force issue reports, annually or on their activities, or how can you find out more information about what some of their work has resulted in terms of impact on the community?
I'm sure they do. The task force is run by the sheriff's office. And so we've been out of it for several years. And so I don't know where you would find that. I can find that out for you and point you in the right direction.
Well, Steve may know, and I assume there are a number of federal partners involved with that as well. Okay.
Yeah.
Yeah, so there are federal partners involved, but to answer it depends on the question you're asking related to, for example, given the 16-year-old, if 911 gets the call as an overdose, then we're limited on specific questions. We try to encourage people to call 911 an overdose call, so we don't want to ask a lot of questions primarily. But when we're asking about the upstream flow, we definitely try to find out who the supplier was so that we can prosecute them, and we have had success in doing that. So the task force does get involved in those investigations if it's requested of them, but normally it would be a notification from the patrol side or us letting them know to look into it. Does that answer the question?
Okay. Stephen.
Thanks, Dan. Thanks for this information, Lieutenant Johnson. When you started your report, you were talking about the blues, the pills, and now seeing more powder. That sounds like straight fentanyl. As a layperson, what I've been reading for a couple of years is how it can show up in what you think are other drugs. And I'm just wondering if you're still seeing that, and how you're assessing the part that mixture, the sort of the surprise overdose plays in what we're seeing in the community.
Yeah, that's a real concern, particularly, when something like that falls into the hands of people that maybe aren't regular drug users. The fentanyl powder, I think, is inherently a little more dangerous for people that are handling it or officers that are running across it. And it's a mixture. It's a very small portion of actual fentanyl, but then it's mixed with other substances. So yeah, anecdotally, we've heard, marijuana laced with fentanyl, and methamphetamine has fentanyl mixed into it now too. We send all those substances down to the lab when we're going to pursue a prosecution. And so I don't really have any, we've seen more of that drug mixture, things being laced with fentanyl, but I have heard that on several occasions.
Just like to add one more thing before we transition over to Captain Larson from fire. Last night we had, first of all, I'm really groggy because we went until like 10:30 last night. It's really hard to manage a city at that late hour. But one of the final public speakers that we had was an outreach worker from the Opportunity Council who goes and works with folks who are opiate use disorder affected. And she had mentioned that they were beginning to see xylazine flesh wounds. So that's what's commonly referred to as trank dope. It started on the East Coast, and apparently it's making making its way west here. Keith, are you seeing anything like that when you get reports back from the lab? Is that showing up in those reports as well?
I've heard the same scuttlebutt. I have not seen a lot of confirmed cases of that around here yet, but I'm sure it's there.
Okay, thanks. Any other questions for Lieutenant Johnson? Hey, well, thanks, Keith. That was great. That was really helpful. I'm going to transition just with a time check real quick here. It's 9:50. We're slated to go till 10:30, so we've got a little bit of time, but just so we're all aware of that. I'm going to move over to Captain Steve Larson from Community Paramedic.
Hey, good morning. Steve Larson, and I was just going to give you guys a little bit background on myself, the community paramedic role and division that I work in, and then kind of address a little bit of the executive order that was developed in the end of February, and then addressing the kind of the fentanyl crisis and overdose from the fire and EMS side of life. Yeah, so Steve Larson, I've been with Bellingham since 2008. I've operated as a paramedic for the last 14 years of that. And I had the opportunity to promote into this community paramedic role last November. So about 8-9 months into it now, still trying to grasp everything. And I am the 4th generation community paramedic here for Bellingham. This program started back in 2014 as a 9-month pilot program, and it started out with a singular paramedic and a van outreach into our high utilizers of the 911 system that were generally not utilizing 911 as a emergent need, and trying to effectively hook them up with the right social services. It then developed into a paramedic and an intensive case manager, which developed into 2 paramedics, intensive case managers, and where today we have 2 paramedics in the city of Bellingham with intensive case managers, and then an additional one out in the county to support the county needs with a. And so we operate out of a couple of vans, wheelchair capabilities, so able to support clients with higher needs there. Historically speaking, we start engaging with people when they have 8+ 911 calls in a 365-day period, however that kind of lays and falls. And that's not a hard number. It's just then it kind of peaks up our interest of the why. Sometimes those are just people that have really complex medical conditions, and it's unfortunate, or they've had really extreme poor luck. And so not everyone gets engaged by us just because they've had 8 911 calls, but we definitely kind of look into it and dig into the deeper why behind that. Some of the criteria that falls of the whys is the aging disabled individuals, chronic medical conditions that are poorly managed, fall risks, elderly that could be simply prevented with some grab bars and other supporting devices, gait belts, Hoyer lifts. And then we kind of get into our other criteria that are kind of our more demanding clients: substance abuse, mental health, and homelessness. And a lot of those play together a lot of the time. And those are the ones that, from my short time here in this position, that take a lot of supports and a lot of energy and resources. And we kind of, my partner put it, we kind of act as a bridge, trying to hook these individuals up with the best services that we have here in the county, and get them the best situation that we can possibly do. Each unit, so there's 3 of our units, 2 that I'm responsible here for in Bellingham, and we tried to carry about a 20 patient load. So, and that number is a soft number as well, where it just depends. Some clients exhaust and take a lot of time and management, so we may work with a 15 client load for a period of time as we're working with an individual with higher needs, and we could go upwards of 20-25 if these clients are able to self-manage to some degree. So right now, between the 2 Bellingham units, we have about 30 clients we're working with all spectrums of different needs and services. And part of decreasing our workload down to the 30 clients was the executive order that came in the end of February there from the mayor, and just so that we could help support the fentanyl crisis and the overdoses here that were occurring downtown. And so part of that order, we moved downtown to the public safety office, which is off of Commercial Street here underneath the parkade, which is great, gives us a pretty centralized location for not only the high density of overdoses that happen for us downtown, but then most of our clients are pretty densely populated downtown. So we're able to get to our clients effectively a lot faster and effectively. The other part of that, we work 410s. And so we end up splitting the units. So one of our units works 410s Monday through Thursday. Myself and my partner, we work Tuesday through Friday. So now getting a 5-day coverage, get an extra day of coverage. And then being physically and visibly more present downtown. We'll cruise the downtown core quite often, looking for our clients, being physically available for them and visibly available for them. And we've also done some outreach and done some Narcan trainings to some of our community partners, like the YWCA, the museum, trying to get some generalized education out there for individuals that are looking to also support our citizens and making sure they have the right tools and training to support their needs. Then kind of dovetailing into overdose and the fentanyl crisis. Today in the city of Bellingham, we still operate with our normal, what is called our echo overdose response. So someone that's called dispatch has been triaged, they get the same resources that someone would get if they had a cardiac arrest, because the layperson in a stressful scenario doesn't really know if someone has a pulse or not a pulse. So we still support them, give them all those resources in conjunction. If we're working with community paramedics, we're listening, we'll get dispatched in addition to that. We'll respond if they're downtown, and hopefully that we can get there first and make a quicker impact. And then if not, and crews get there and the individuals are resuscitated, we try to weasel our way in and take patient care. And I think that what that looks like is, instead of approximately 10 people in uniforms hovering over you after you've been resuscitated, we try to peel those individuals, coworkers back, get them back into services. And then my intensive case manager and I try to take over as best we can, pending the individual, and giving them the best tool that I think we can give them is time, and whatever their needs are to support them moving forward, and trying to encourage them to a detox and a hospital, and then being able to try to follow up with them at 24 to 48 hours later. In terms of numbers and relevant to fentanyl, I was kind of looking at our dashboard within the fire department, and back in November of 23, and I'm sure these are some soft numbers as well, but we were averaging about 2.28 fentanyl overdoses a day in this city. That's not the county, but just the city here. And I just looked for from March to now, we're down to averaging 1.02 overdoses a month, or per day. And it feels like it. And why has those numbers decreased? I don't know. There was a period there that I understood the fentanyl got broken up and there was no distribution up into Whatcom County. And it definitely felt like it, because it went from overdoses pretty regularly to none for like a whole week. And then I understood the detoxes were full and felt that surge as well. But fentanyl's still in the system clearly today, but the numbers are down. The numbers are showing down, and I can say I'm definitely feeling like those numbers are down too. It's been a while since I've been on one. Mind you, I only work 4 days, 410s, but so I'm missing a couple days. But yeah, the feel is definitely lower as well. Yeah, and we've had a couple success stories working with the DCRs in terms of reoffending clients that are overdosing, and they use the term poor faith follow through. So these individuals are resistant to seeking help, coming with us to the hospital, utilizing resources, and they say, "Oh yeah, sorry, that was just a one-off," which we clearly know wasn't. They've overdosed many times before, utilizing emergency services, resuscitate them, so they just don't have the capacity and tools to not overdose again. And so the DCRs have taken a couple of our clients and been able to get them down to treatments, involuntary treatments, for quite a long stay, 2+ weeks down south. And so we're looking at maybe that is something of clients that we have these reoccurring overdoses that are getting resuscitated, kind of working that angle to try to support these individuals that are unable to support themselves. And then what are we doing moving forward? Is a kind of a good question. At this point, we're in the emergency side of life. On the medical side, we're kind of reactionary. So I guess I'm trying to scratch my head, and that'll be kind of my personal homework of like what I can do to be proactive in this crisis and overdose to try to get ahead of this curve a little bit more. But I'm excited what you've all talked about and being part of this group and working on this plan together. And happy to field some questions if anyone has any.
Any questions for Captain Larson, Dr. Wu?
Captain Larson, thanks for that. I'm just curious, do you have a sense of what the age spread is of your clients?
Oh, I'm sure I could find it, not quickly out of hand. Yeah, as when we were going back to like the 16-year-old or whatever, that's not a regular. I'd put them anywhere from their 20s to 50s in a huge range, but I'm happy to get our data analysts and try to find that number. But yeah, I'd go from in their 20s to 50s is pretty common. But we do have we do get the occasional extremes as well.
Mm-hmm.
Peter Fraser.
Thank you very much, Steve. Really appreciate it. So in a city of 90,000, we have about 30 individuals who are cycling through 8 911 responses a year. Is that correct? Is that what I'm hearing?
Yes and no. Yeah, some of them. Let me try to. I should have had this little. We only have the capacity to effectively work with 20 clients until we're just. It takes a lot of work and a lot of coordinating of resources and services. So we physically only have the capacity to work with 20. We could benefit by 2, 3, 4 more units in the city because that need is there and those clients are there. But we're just trying to work with those top, and those tops, like we have an individual that called 82 times since January of 2023, and he's had 82 911 calls, and we're doing everything in our power to try to support that and decrease that and hook them up the right resources. And there's just some roadblocks. And so, yeah, we're not touching clients that are down at the 8 calls a year. We're up in the double digits, the teens.
I see. Yeah. Okay. And do you have metrics to show that the emphasis on high utilizers is overall working throughout the system? Just curious whether that is something that you are monitoring and show, each reporting period.
Yeah, I think that data is achievable, and it's clearly felt by crews because when we're not here on the weekends or overnight and these poor individuals call because we're not a resource available to them, we get alerted, and crews let us know that they saw our clients and stuff. But it is kind of like, it's kind of that hard, there's some hard data to show as well that, well, we've engaged with that patient 20 some times. So just engaging with them, does that mean there was 20 less 911 utilization calls, keeping those services available? Not necessarily, because we could see them and then we go home at 5 o'clock and then they call. But do I believe that we're having an impact? I think we're having a massive impact. Yeah. And it's just some challenging, hard information to say just because we've engaged with these clients, they're decreased 911 utilization. But yeah, I can tell you when we don't engage with them, the 911 calls are increased.
Yeah. Thank you very much. I appreciate it.
Yeah.
Cedric.
Thanks so much for the presentation. When I worked at Unity Care, we had a lot of staff who interacted with the community paramedicine program. So I'm really glad to hear that it has grown. You sort of answered one of my questions, which was about the need for more, which sounds like we would benefit from, I think you said 3 to 4 more units. One of the things that I heard a lot about when I was at Unity Care, and this is kind of secondhand because I was not working directly with this population or with your program, was that there was a lot of burnout among the individual community paramedics. That I think there was a lot of interest in the program and excitement and passion, and also that just the work is really intense. So I'm just curious if you, well, 2 things. What are the typical terms? I think you said you've been doing this for about 9 months. And so how long do people typically serve in the community paramedic role? And, you know, how do you think we're doing supporting you and the rest of the staff in this program?
Good question. Yeah. And I can only speak from my experiences and my cohorts. But the person that I replaced, it's a rotating position. I think they asked that we serve a year here, but historically speaking, people have spent more time. So the individual I replaced, Captain Frank, he spent over 5 years in this position, and that was because he enjoyed the work. And I don't think people get burnt out. I think that it's more of like letting someone new come in to bring in new ideas, not necessarily better ideas, but different perspectives, new ideas. And so this position that I'm in is a rotating position within a few others within the fire department. So along with many other kind of positions that just fluctuate new ideas, thoughts, and ideas through it. But yeah, I can tell you at 9 months, I'm not even close to burnt out. So I would enjoy spending many years in here. And yeah, my other coworkers in here are kind of, I think, in the same boat, and it's been great. So we're kind of in a unique situation in the fire department. You have to have a minimum of 3 years as a functioning line paramedic before coming into this position, just because we want them to have paramedic experience. And we have a really young paramedic cohorts right now in our department. So we've had some good youth and energy in our department, but we just want to get them that experience before they come into this untraditional role and more. Yeah, there's a lot of moving parts in here. So we just want to make sure they have the tools before throwing them in here.
Thanks.
Yeah.
Brian.
Yes, I had just 2 quick questions. So you operate, as I understand it, mainly weekdays, like during normal kind of business hours. Who takes those calls when you're not, your program's unavailable? And this might be a question for Melora as well. So your program is distinct from GRACE and ART, or is there some overlap between your program and GRACE and ART?
So first, your answer the first question, who answers the calls from my clients? 911. So our clients will call 911 and normal EMS crews will go out and service those individuals and as fit. Yeah, there's other programs out there that have 24 hours, but I think majority of them in the community paramedic outreach role are daytime hours only. I don't think see a huge benefit from when these clients are sleeping. Hopefully that could benefit. And the coordinating with other services, most other services we work with are not 24-hour services. So services that are available at night, typically speaking of late hours, are 911 and the ER. So I think that's kind of why we've stuck to like a normal business hours aspect with this division. And then, yeah, the second part of your question there, yeah. So the intensive case managers are part of the GRACE team in the county. And so my partner and I work hand in hand together, and they are definitely the brains of the operation and have the ability to hooking individuals up to correct resources and services. So I lean on them a lot. Once I work the paramedic and medicine side of it, and they are doing more of the services oriented and management side of life for these individuals.
Yeah, and I can just add, Brian, so, you know, the community paramedics have always been an essential component of the GRACE model, and yet, you know, community paramedicine and mobile integrated health is its own work inside of EMS. And so it's been many years of us doing this partnership where we're able to provide the intensive case management. Fire and EMS are providing the community paramedics. And I would say we do have GRACE utilization data that's available that, you know, would reflect a lot of what the community paramedicine work has, the impact that it's been having. But they would have additional data on top of that for the folks that they see just in community paramedicine, above and beyond folks that are enrolled in GRACE. And I'm happy to share that data here at any point. What we've seen in the last 5 years is an annual average reduction of 83% of EMS utilization for folks that have graduated from the GRACE program. So pretty significant. But again, I think that Bellingham Fire and Ferndale Fire could provide additional data on top of that. That would be an enhancement. And to add, and just really quick, the second piece, the alternative response team is a law enforcement diversion program, not an EMS diversion program. So, you know, Steve can speak to if they interact with the alternative response team in the field at all, but it should be quite rare since they're going to calls in lieu of law enforcement, not going to calls that would be set aside for or sent to EMS. But Steve, if you have anything to add to that, that'd be great.
Yeah, we don't work with them on a daily basis, but I would say a regular basis, and keep in contact as we have mutual clients. And so kind of, yeah, in fact, we talked to them on Friday. It was just a common client that what was going to be the best resource for them. So yeah, they are a great resource out there to work with and partner with.
Okay. Dr. Wu.
So this may be things that you already know, but I just wanted to comment that for several years now, there have been many published studies of what are called hotspotting programs, like community paramedic type work in many cities throughout the country. And the kinds of dramatic decreases in ER utilization and paramedic calls and the significant cost savings have been a pretty steady finding through most of those studies. And it's great to see that, you know, the fire department here has made a commitment to doing this on an ongoing basis, because a lot of those programs were on soft money and ended when the money ended. But the fact that we have a stable situation and a commitment to that, I think, is really huge. So thank you for the work.
Yeah.
Excellent. Steve, anything else that you wanted to add, or?
No, thank you.
Okay, well, thanks for presenting. And let's move along. We're at 10:14 and we still have a couple of items here. So Dr. Wu, do you want to provide us an overview of the all hands and any impressions? I would also welcome Heather to provide any feedback as well.
Sure. So just quick background. So all hands, this was the second 2-day summit. Had one last year. It was put together on very short notice. This year we had a little more advanced planning. And I'm going to say we, but truthfully, I did almost none of the work. Mostly I just made the coffee, but it's just for shorthand. When I say we, I mean the team at Chuckanut Health Foundation. So there was a ton of stuff that happened. I would say the energy was really good. I'm just going to try to capture a few highlights. Overall, I would say, and just a little more background. So this is a response to specifically the opioid crisis in the community, and an attempt to bring community voices together to look at what are possible, to bring everyone up to speed on data and then to look at possible solutions. The first year was more general. This year was specifically focused on youth. I'd say overall, fortunately, my overall sense was one of hopefulness. It was like a gathering of very action-oriented people who were already activated, people who were already thinking and planning, and many of them were already doing the work. Most of those folks need support. They need to get word out about what they're doing. They need help getting to scale. But there's a lot of work already happening. We had a lot of input from the youth themselves. And what I took away from that is that they are talented, they are energized, they are ready, they know what they need, and they are willing to tell us what they need. And that what they're telling us they need really aligns with good evidence-based approaches. So there's really no conflict between what they're asking for and what evidence would tell us to be doing. What they lack is access to resources. They lack access to power. And for now, I think they're giving us the benefit of the doubt to see how we respond. They're waiting, I think, for a response from us. And are we going to join with them? Are we going to stand with them? Are we going to let them in the room where like they said in Hamilton, they want to be in the room where it happens. And I think we would really benefit from having them in the room where it happens, where the decisions are made. And are we going to bring ourselves alongside them so we understand really what their issues are? They're willing to tell us, and I think we really need to listen. What they specifically said they wanted: intergenerational mentoring and support and resources. So they know that they don't know everything. They know they don't know how to operationalize a lot of stuff, but they know what they need and they want to work with us on that. They need more trusted adults. And they see that for them to work with trusted adults is actually healing for the adults, right? Because the whole community is traumatized by what's going on. So there's healing for all of us in this. They want safe third spaces, safe spaces where they can gather, where there's no cost and no barriers. They need to be free, accessible, respectful of everybody. And I'm just going to use this word intentionally. And this is a quote: that love has to be our greatest effort, right? So love doesn't come up in policy discussion a lot, but it came up all the time throughout the whole summit. And I think that's really important, because lacking that significant emotional level of commitment, I think it really impairs the work to think of it just as policy. So then we heard from adult panels as well. And we heard from a wide variety of folks. And I think one of the things that was really encouraging is that we heard from people who have decision-making power. Folks who are elected officials, policymakers. We heard from the Office of the Superintendent of Public Instruction. So it was that, and I think that gave people, and the youth specifically, a lot of optimism, because I think they feel like they're getting a little more access to decision-making. And I think that's really important that we continue that. I would say the most quoted statement that I saw in all the feedback forms that came back was what one of the young folks said. They said, "Community begins where judgment ends." I saw that quoted probably a dozen times in the feedback forms that we got. And it really, I think, is important that we change our entire culture about what this problem is. So the judgmental, punitive, this is a individual problem, this is a behavioral issue of a specific person, is really not getting it done. And the kids are aware of this. One of them said, where was it? Society is the patient, and connection and sustained attention are the treatments. It's really not about individuals. And there's another quote: "Belonging is not needing to hide any parts of yourself around other people." So the whole piece about shame, I think, is not working for us. The representative from one of the representatives from Lummi Nation presented information on what's called the Icelandic prevention model, which got a lot of traction, I think, with the audience. And very simply, it encompasses a lot of the other suggestions that people made. But the idea of this is that the entire community takes responsibility for creating a community which is safe and nurturing for youth to grow up in. And that incorporates third spaces, it incorporates safe mentoring, it incorporates volunteerism, it incorporates public policy, and that it's the responsibility of the adults to create this, and that the focus of it is on the youth growing up normally or growing up safely, so that it becomes the norm and the expectation, and that anything else would be as unacceptable as driving, north in the southbound lanes on I-5. It just wouldn't happen, except in rare instances. So I think that cultural change was a big message from the, for me, from the summit. I think people are really, they're proud of coming together. They were glad to be there. Someone said they want to do this again next year because they felt like it was, quote, bathing in hope in a loving community. So I think that points to the need for having sustainable support for doing the summit annually going forward. And then I'm going to quick bullet through a whole bunch of specific suggestions. One of the teachers told us 3 by 3, right? Make 3 contacts with us in a supportive, I can't remember exactly what the 3s were, but it was like 3 seconds of supportive contact with 3 kids every day. Was a simple goal that she had for herself that she thought was difference, and that got traction with a lot of people. I saw that quoted multiple times. And then here's a list of things that are already happening that all need support and can scale. And they range from kindergarten to adulthood. So starting off, there's a program called Roots of Empathy, bringing infants into classrooms in elementary school has been shown to have demonstrable improvements in empathy in kids, reduction in bullying. There's a person working on a program of transforming educational curriculum, since we're basically following a 150-year-old curriculum and isn't really working for students in the modern world anymore. A lot of work around trusted adults. There's a group called Community in Schools that is bringing additional adults into schools to help with kids identified by the school as high risk. This is down in Mount Vernon, but there's Officer Carlson, who's a school resource officer, who has a very popular class that he's working on, teaching kids about criminal justice and substance use. There is a group at Generations High School working on what they call blurring the division between school and community through civic mentoring. The public library has a program that they need help popularizing and figuring out how to lower barriers so they can improve engagement with kids. There's another person working on equitable access to sports. One of the art teachers who presented amazing student artwork at the summit is interested in starting an art center as a healing process. There's the Northwest Youth Services. They're celebrating youth program. There's the public defenders are working on youth diversion. There's Teen Court. The YWCA is working on new low barrier housing for moms with young children who are having substance use disorder. There's a direct cash transfer app program that Northwest Youth Service is piloting. There's a lot going on. And I think one of the specific thoughts that I had coming out of this was everyone in this room, everyone in this Zoom room could grab one of the kids who was a panelist at the summit and bring them into the room with us and let them be our policy advisors. They would tell us what we don't know as opposed to listening to ourselves. That's what I got.
Thank you. Thanks, Dr. Wu. Any questions, or Heather, did you want to add anything?
That was an amazing summary. A couple of are that sorry, hold on. I had the privilege of facilitating the elected officials panel. Thank you, Dan Hamill, for being on that. And the energy and excitement and heart was so palpable with the elected officials on that panel. You included President Councilmember Hamill, and then hearing from the youth, there was such a disconnect. I just felt like there was a disconnect between the energy and the momentum and the conversation that even task forces like us have, right? All of the activities we do and the decisions we make and the policies we're trying to set and the funding, and yet our youth are still experiencing really hard things and telling us that some of the policies that we've set are actually harmful to them. And so I want to help bridge the experience of everyday people with the hearts and vision and leadership of our elected leaders and of task force members and all of that. And then related to the Icelandic prevention model, but a little different. A few months ago in March, All Hands also hosted the Native Transformations event. I hope some of you were able to come to that. And the ReefNet wellness model was presented. And I think that would actually be a very worthy presentation at this committee and in all of our departments. One thing that I loved about the ReefNet wellness model, it shows really beautifully the conditions for health in a community, what we call social determinants of health. But it also puts the responsibility for when a fish gets lost from their school and their community, it's the school of fish's job to go find the lost fish and bring them back. And I think a lot of us here have that heart, but not everybody in our community does. And so often we say it's that lost fish's responsibility to come back to the school and figure it out and find their bootstraps. And they're just, they're lost and they got to find their way back to us. But the model is flipped in the ReefNet model. And I think that we need to actually do that, finding the lost fish a lot more in so many ways and levels if we actually want to get anywhere near where we need to be with the opioid and fentanyl crisis. And I also want to say that I see Dr. Bosted in the attendees, and maybe he'll make a public comment, but I just, he was a big contributor to the planning and to the program too. So thank you, the attendees. Bosted. Oh,
Thanks.
there you are.
Thanks for the presentation, Dr. Boone and Heather. I think I'm getting some feedback here.
Hello, sorry, Dan. I was just responding. I really appreciate the event and anything that I'm ever able to do for this community. I'm more than happy to do. And for any of you, if there's specific information about the medications for opioid use disorder, I'm more than happy to tell you. I will say, in listening, it seems like you are all very even pretty knowledgeable for most people about this treatment model. So I don't know exactly how much more I have to offer, but happy to do so. So thank you.
Thanks, Doctor. And I personally would like you to come back in August and maybe present a little bit in more finer detail on those on MAT and other treatment modalities. And then we're almost at time. We're at 10:29, and I want to respect everyone's time. We do need to go to any other public comment, but I do want to recognize Brian. You get your hand up.
I just wanted to clarify, especially for our new members, Dan and Stephen and Heather could comment on this, but our purview in this committee is just people who are 18 and older. So I would also recommend that presentation that was given be given to the behavioral health group at overall Whatcom County, because they do specifically deal with youth mental health.
Dr.
And
Booster.
you made it.
Yeah, Dr. Booster, I think you've got your mic on. Can you just mute it real quick? It's just getting feedback. Thank you. Got it. Okay. Dr. Wu?
Oh, I just wanted to say youth mental health turns into adult mental health. I think it's totally within the purview of this committee. Not that I'm disagreeing about the other need.
Well, frankly, I think we need some clarification on that moving forward, Dan and Stephen, because we've talked about this multiple times in the past.
Yeah, so this group is a bunch of rebels, and we don't necessarily follow the mandate. Because I agree 100%. There's a bunch of us on this call that totally recognize if we just wait until people are adults and they get into the system, it's harder to create solutions. It's better to go upstream. We've had this conversation for years, and yes, I will get you more clarity on the mandate from the charter. And Jill Nixon can help with that. We're out of time. We had the last item was to look at action items for the rest of the year. Basically, there were 16 action items. There's no way we're going to get through that today. I need to respect people's time. And then in listening to Dr. Wu and Heather from Chocolate Health, I think there are some things that we could be integrating into the to-do list based on some of the feedback. And yes, some of them are related to youth, and I think that's okay. Jill Nixon, anyone for public comment?
Thank you, Dan. We do have a number of attendees. If any of you would like to speak to the committee, please virtually raise your hand now. I don't see any hands raised. Peter, do you have anyone in the conference room with you?
I don't. I'm here alone.
Great. Thank you, everyone.
Okay, great. Thanks. I just wanted to thank everyone. Thanks to all the folks that are new to the group. And we'll have another meeting. I don't have the date in front of me. Jill, do you have that?
It is August. One moment. August 20th.
August 20th. Okay. Thank you, everyone. Have a great rest of your day. It's beautiful.
Yeah, Dan, Stephen, could you stay on the call for just like 3 more minutes?
Sure. Thank you, everyone. We're adjourned.